Now we'll be having our next speaker for the session, Dr. Sivaranjan Thandeswaran sir, MRCP UK, stroke physician and senior neurologist, Cauvery Hospital. He finished his MBBS at Raghunandan Medical College and his MRCP in internal medicine. Sir specializes in stroke and neurovascular medicine and received the best research poster at the Oxford University Nuffield Department of Medicine. To encourage our patients to grow through what you go through, we doctors must be skilled enough to sharpen our skills enough to treat a persevering patient. We call upon our speaker to present on the topic diabetes and stroke.
Firstly, a big thanks to the Internal Medicine Department at Tagore Medical College and Professor Sharavan for organizing a wonderful conference, and also a big thanks for allowing me to come here and talk in front of you. And so I'm going to focus on diabetes and stroke. And so you all know the definition of diabetes. And why is it diabetes very important in stroke? So there's a lot of studies that looking at diabetes and coronary artery disease and heart failure and so on, and also in CKD. And yes, there are quite a few studies that look at the incidence of stroke in diabetes. And diabetics have threefold higher risk of ischemic stroke. And when someone comes to hospital with stroke, there is a likelihood that 10% of those patients have undiagnosed diabetes. And that means they have diabetes as a first presentation when they come in with the stroke admission. And of all your stroke admissions, if you look at the sugar levels, almost 60% of your stroke patients will have dysglycemia or elevated sugar, even if they have diabetes or they don't have diabetes. Due to stress, they may have elevated sugar levels at the time of admission. So why is it important? If somebody has high sugar levels, they are found to have poorer outcomes, and there are quite a lot of studies that confirms if your admission sugar is pretty high, the long-term outcome is poor. And when someone has elevated sugar, they have increased risk of atrial fibrillation in hospital. They tend to have increased cerebral edema around the infarct or bleed, and they tend to have lower GCS and slower recovery. They have higher infection rates, especially aspiration pneumonias or UTIs, leading to prolonged length of stay in hospital. Often they tend to have higher rates of delirium and post-stroke dementia. They tend to have higher risk of seizure post-stroke, and there is an increased chance of recurrent strokes during their stay or even after discharge. So there are some factors that can predict who will be at a higher risk of developing stroke in the community with type 2 diabetes. And the top of the list is proteinuria. Protein is a very good predictor along with higher systolic and diastolic blood pressure for risk of stroke. Same is true with higher fasting blood sugar of more than 200 and a HbA1c of 9.5. Same is true with hyperuricemia and age more than 60. So what drives stroke in diabetic patients? So we all know that patients with diabetes tend to develop microvascular and macrovascular complications. And within the macrovascular complications, you know that the atherosclerotic plaque plays an important role in development of stroke. So this is probably quite a frequent slide you would have all seen. So the underpinning thing in atherosclerotic plaque is the lipid core, which is formed by lipid core with foam cells and monocyte migration into the endothelium with high inflammatory plaque. And the plaque, as it grows, can rupture into the surface of the endothelium and cause thrombogenesis into the lumen. And you can get artery-to-artery emboli or thromboembolic phenomena causing strokes. So if you look at the atherosclerotic plaque formation, there are certain areas in the body they are more prone for developing plaques. Commonly, you would have seen patients with stroke having carotid stenosis or carotid plaques. Often they tend to have arch atheroma, and quite often those patients will also have coronary artery disease or peripheral vascular disease. And in this study, looking at prevalence of vascular distribution and multi-territorial extent of atherosclerosis in a middle-aged cohort, so they found that the incidence of atherosclerotic plaque was highest in the peripheral vascular disease, iliofemoral area, and followed by carotid and coronary and abdominal aorta. Same is true with men and women. If you look at age pattern of where the atherosclerotic plaque is, if you look at the extent of the same plaque in different age groups, it still remains the same. You can see the iliofemoral area tops the list with almost 72%, followed by carotid and coronary and aortic disease. So this is a good information. If somebody is in front of you with, say, any form of suspected atherosclerosis, they have a long-standing diabetes or dyslipidemia or hypertension, the simplest thing is to check peripheral vascular disease. If they have no peripheral vascular disease, it's most likely they will not have coronary disease or carotid disease. So useful information to look at their pedal pulses in the outpatient department. If they have a very good pedal pulse and if they have no history of claudication, then you can move on to concentrate on other things. Okay, so the short-term risk for stroke is almost double in persons with newly diagnosed type 2 diabetes compared with persons without diabetes. If you look at this graph, so across all age groups, the highest risk is there obviously in the elderly, followed by, if you look at any age group, the risk is pretty double in terms of incidence of stroke. So just briefly, I just want to talk a little bit about stroke here. So I'm sure during medical school you would have been taught about classification of strokes. So if you look at the incidence of stroke, 85% are going to be ischemic in nature and around 15 are going to be hemorrhagic strokes. If you look at if you break down the ischemic strokes, 20% will be large artery atherosclerosis, meaning they have arch atheroma or carotid disease or vertebrobasilar atherosclerotic disease causing artery to artery emboli. Next common is small vessel disease, typically seen in diabetic patients and hypertensives where you tend to see lacunar infarcts. The third common is cardioembolism due to mitral valve disease or atrial fibrillation or dilated cardiomyopathy causing LV thrombi, causing a shower of emboli into the brain. And despite extensive testing, almost 1/3 of your patients will not have any etiology. And quite often they are younger, and some patients may go on to have issues like atrial fibrillation in the future. And this is after testing for PFOs, thrombophilia, and everything. You may still be left with 1/3 of your patients not having any identifiable cause for their stroke. So if you look at hemorrhagic strokes, equal percentage for intracerebral hemorrhage, likely due to hypertension or amyloid angiopathy, which is commonly seen in elderly, and arachnoid hemorrhage due to vascular malformations or aneurysms. And quite often, these last two types of strokes are missed, especially cortical venous sinus thrombosis, which is getting more commoner with alcohol abuse culture in our society. We do see quite a lot of youngsters with high incidence of CVT, dehydration, and the other elephant in the room is silent strokes. A lot of people with undiagnosed or poorly controlled vascular risk factors tend to develop silent white matter hyperintensities on their routine scans, which may not have motor symptoms, but they tend to develop dementia, gait imbalance, urinary incontinence, and so on. So when I was in medical school, I wasn't aware of this particular classification, and I'm sure this is not routinely taught in medical textbooks. So if you look at stroke patients and if you broadly divide them into ischemic or hemorrhagic, it doesn't serve the purpose. You have to further break down your ischemic strokes into further subclassifications because it has got quite a lot of prognostic and treatment implications. So anterior circulation strokes, posterior circulation strokes, and lacunar strokes. These are broadly three major groups, and within that anterior circulation, you can divide them into total anterior and partial anterior. And you have clinical features which say if in anterior circulation strokes, which is simply due to middle cerebral artery strokes. If you know the middle cerebral artery is has a stem followed by three branches, one to the frontal cortex and another one to the insular cortex, and the third one that goes to the parietal cortex. And they also supply the superior temporal lobe. If one of your branches is occluded, you get a partial anterior circulation stroke, maybe on the anterior branch or a posterior branch. If the whole stem is occluded, you get a total anterior circulation stroke. So posterior circulation strokes is anything that causes infarcts in the PCA territory, cerebellum, pons or medulla, and you may be having isolated hemianopia or brainstem stroke syndromes and so on. So lacunose strokes are very interesting because they have very tiny infarcts but quite a lot of devastating effects. If it involves a posterior limb of internal capsule, you may have a pure motor weakness and recovery may be slow. If you have a small infarct in the thalamus, you may have a pure sensory stroke. And you may have, in thalamus and pons, you may have what we call as ataxic hemiparesis, and in coronary radiator infarcts, you can get clumsy hand dysarthria syndromes. So these little example CT and MRIs shows how a TAX, PAX, POX and LAX may look like. So there's another classification called TOS classification. So what you saw earlier was Bamford classification, Oxford Community Stroke Project classification. TOS classification is quite extensive classification which groups your patients based on the etiology, whether it's large artery like atherosclerosis or cardioembolic lacuna, and you have to break down the TOS classification with possible and probable after your extensive investigations. So why is it important to classify your ischemic stroke patients? If you look at data, so almost 40% of total anterior circulation strokes do not survive beyond a month. And it's very useful information to talk to family and tell them how they are supposed to spend their resources, how much effort they should put into long-term physio and so on. So who should be having space in your ICU and who should you not treat in ICU? If somebody has a total anterior circulation stroke and aspiration pneumonia, the chance of survival is only 10%. And same way, at 1 year, nearly 60% of patients with TAX are not surviving. But if they have had an anterior circulation which is partial, the survival is much better. So it's very important to classify your patients according to TAX, PAX, LAX and POX. So 20% increased mortality in those with admission hyperglycemia on top of this information. So if somebody has elevated sugar, they may have diabetes or they may not have diabetes, they may have stress hyperglycemia. So even that increases their mortality. So your target should be to keep the sugar between 140 to 180. So that's the latest American Heart Association stroke guidelines. And even a lot of studies have been looked at strict sugar control post-stroke, but all of them were not in favor of intensive sugar control, mainly because the trials had quite a lot of patients with hypoglycemia which nullified the positive benefits of sugar control. So we should be careful not to cause hypoglycemia. So what happens with a normoglycemic brain and a hyperglycemic brain? So you all know there is a core immediately after stroke surrounded by a penumbral tissue. And the penumbral tissue is a salvageable tissue. That's where you try and give your IV thrombolysis or take your patients for endovascular therapy where you can do a thrombectomy and restore the vascular supply. But in a hyperglycemic brain, so there is increased so there is impaired recanalization due to increased thrombin, antithrombin complexes. So as you can see, the infarct gradually increases in size, and due to decreased perfusion and increased reperfusion injury, even if there is reperfusion, the penumbra eventually gets destroyed. And that's mainly because in a diabetic brain, you have a higher risk of blood-brain barrier dysfunction or blood-brain barrier breakdown due to quite a lot of these metabolic and cytokine pathways. So the most feared complication after IV TPA is hemorrhagic transformation or hemorrhage into the brain. So this slide shows different types of hemorrhagic changes after IV thrombolysis. And if admission sugar is higher, the risk of hemorrhagic change is almost 50% in those patients. So it's very important to check the sugar before giving IV thrombolysis. And you all know IV thrombolysis is licensed up to 4.5 hours from the onset of stroke. If somebody has woken up with a stroke, you may not know the onset time. In those patients, you can do a diffusion flare image and check for diffusion flare mismatch. If there is no flare positivity, they can still be taken for thrombolysis or thrombectomy. So for the students, I just want to let them know there are different ways of classifying hemorrhagic transformation. Hemorrhagic infarction type 1, type 2 and parenchymal hemorrhage 1 and 2. So if you have isolated petechial staining of infarcted tissue without any mass effect, that's hemorrhagic infarct type 1. If it is confluent, it is type 2. Same way, if the infarct tissue has a homogeneous high attenuation lesion with minimal mass effect, less than 30% of the infarcted tissue, it is parenchymal hemorrhage type 1. And if it is more than 30% with a bit of midline shift or any intraventricular extension, you call it as PH2. Again, there are a lot of reasons why we want to classify various pathological changes, because the prognosis varies. If somebody has PH1 or PH2, the risk of edema, risk of decompressive craniectomy and so on is higher. And most patients after thrombolysis or recanalization will have at least H1 or H2. So that's pretty common to see, and quite often we feel happier that somebody has a tiny hemorrhagic transformation, mainly because we know that the artery has recanalized and they're going to have a better outcome. So again, for the sake of students, I have a slide here to quantify the prognosis after intracerebral hemorrhage. So this is a good score you can use. So first you have to look at the GCS and grade it according to whether it's 3 to 4, 5 to 12 or 13 to 15. And then you calculate the ICH volume. You take the largest diameter of your ICH and use your cursor on the CT scan to get a 3-dimensional volume. So A times B times C divided by 2. And if you use that against that table, so if you have a score of 1, the risk of death and disability is almost 13% at 30 days. If the score is 4 and above, or 5 to 6, they are going to have 100% mortality. So we often have this very tricky situation with family and relatives where they have a sudden onset ICH and you don't know whether you should put them through surgery. Are they going to get better? Neurosurgery is not a simple thing, and ICU stay is going to be prolonged. They may end up with tracheostomy. But if you know that the score is 4 or 5 and 6, they're going to have almost 97 and above percent risk of dying at 1 month. So you can tell the family that despite what we do, they're not going to survive. And you can redirect your resources and save the family's resources of what should be done, what shouldn't be done for any particular scenario. So I'll just skip this slide. So this is a very good trial called ATTACH trial. It looked at rapid blood pressure control post ICH. The target was 140/90. So you all know there are a lot of treatment available for ischemic strokes, but in hemorrhagic strokes, apart from blood pressure control, which has found to reduce the hematoma expansion and limiting the risk of further surgical intervention, there's nothing much that has been proven to help. There were trials looking at factor 7, tranexamic acid, and quite a few agents that has been used, but none of them showed a positive benefit. The ATTACH-2 trial in a subgroup analysis found that in those patients with normal glycemia, there is still a 30% risk of death or disability at 3 months. Even if they have moderate hyperglycemia, meaning 140 to 180, or more than 180, which is severe hyperglycemia, the risk of any major death and disability is almost more than 50%. So it's very important to control their sugars as soon as they come in. So it's an example of atherosclerotic disease and small vessel disease. So you can see on your left side, there is a huge plaque in the internal carotid artery origin. And on the right, you can see multiple varieties of atherosclerotic plaque in large arteries. You can see top of the basilar atherosclerotic disease. Here the whole basilar is affected. It's a mid-basilar atherosclerotic disease. And here you can see the right MCA is invisible, so leading to internal watershed infarcts. And it's a nice scan showing absent flow in the left lenticulostriate vessels causing infarcts in the corona radiata and the anterior frontal lobe. And this slide shows presence of microbleeds in the thalamus. These are typically seen in those patients with hypertensive disease and poorly controlled diabetes. So what happens in those with poorly controlled hypertension is the risk of microbleed increases and the risk of ICH goes up. So in elderly, the risk of ICH is higher mainly because of cerebral amyloid angiopathy. So I'll just show you a real case scenario. So a lady we treated recently in our hospital at Kaveri, Chennai. So a 62-year-old lady who is a chartered accountant has reasonably controlled hypertension, but type 2 diabetes wasn't properly controlled. She came within 2 hours of onset with acute left-sided weakness, dysarthria, and mild confusion. Her admission blood pressure was 200/100, heart rate was 88 regular, and she had a slightly, very high capillary blood glucose. So I just want to ask, what would be a next important step in management? So anyone want to raise your hands with the answer? So would you want to lower the blood pressure or not? You would send them for urgent brain and vascular imaging. Would you quickly correct the sugar or all of the above?
Postgraduates, you can answer. Some sort of exercise for you only. So which one you target, the sugar, BP, or all of the above?
Okay, so it's pretty obvious. You would want to do something for everything. Okay, so the problem with lowering blood pressure in those with any vascular risk factor like hypertension, type 2 diabetes, they are most likely to have critical aortic stenosis. So you don't want to lower the blood pressure dramatically. So quite often, even during my college days, we used to squeeze sublingual nifedipine as soon as we see patients coming with hypertension, and that's a very bad thing to do. So because what happens is they may have autoregulatory mechanism pushing the blood pressure up to perfuse the brain, and as soon as you give sublingual nifedipine, the penumbral tissue gets completely destroyed. So there's a relative hypotension, and the core gets eaten up into the penumbra. So it's better not to lower the blood pressure unless you're going to give IV thrombolysis. And even if you're going to IV thrombolyze them, the target is only 185/100. So you don't want to lower beyond that. So a simple 5 milligrams of labetalol will do, or 10 mg of labetalol IV will do. And just observe them. And sometimes if you check their blood pressure, after 5 to 10 minutes, it may have slightly trended downwards. So yes, obviously we need to do urgent brain and vascular imaging and correct the sugars so we can negate the issues of poor outcomes in the future. So she had a tiny infarct in the anterior frontal lobe, and she had a very tight carotid stenosis on the right. So she had IV actrapid, stat, and followed by infusion, and she had her IV alteplase. The image was done simultaneously, and she had a carotid surgery done within 1 week of admission. And she's doing perfectly well. And she has got slight paresthesia on her left face from the scar on the right frontal lobe. So most of the patients with diabetes and hypertension tend to develop lacunar strokes. Lacunar strokes are simply due to perforator disease. So as you can see, lenticulostriate arteries supplying the caudate, lentiform, thalamus, they are all end vessels. They reach into their tissue and they stop there. They don't have any collateral flow. And same way, the end vessels from the pons, around the pons from the basilar and vertebral arteries, they're also vulnerable for lacunar strokes. So diabetes, hypertension, smoking increase risk of lacunar strokes, and they're simply due to not due to direct atherosclerotic risk. They're to arteriosclerosis, lipohyalinosis of the end vessels. The arteries get thickened inside, and often they develop microaneurysms. And when the microaneurysms rupture, as you can see on the top left, they tend to develop thalamic bleed or pontine bleeds. A lot of hypertensives come with thalamic or pontine bleeds. So 3 times higher risk of lacunar strokes in diabetes. They tend to involve predominantly posterior circulation, and they have higher incidence of intracranial stenosis as well. So this is different types of lacunar strokes. And slightly coming to cerebral small vessel disease, there are different types of cerebral small vessel disease. So you have white matter hyperintensities, lacunes of presumed vascular origin, you have enlarged perivascular spaces due to blood-brain barrier dysfunction. So these are the ones that often are reported as Virchow-Robinson spaces. And cerebral microbleeds are often mislooked actually. So microbleeds won't be visible on your routine CT scans or even T1, T2 flare images. They'll only be visible on GRE or SWA sequences. So if you have someone who is elderly, who has increased prolonged duration of diabetes, hypertension, it's better to ask for that particular sequence. Otherwise, you will not have that information. And especially if you are going to give them dual antiplatelets, or if they have atrial fibrillation and you want to know their future bleeding risk, it's always better to ask for GRE or SWA sequence and make sure they don't have microbleeds. And even if they have microbleeds, we don't worry even if they have it, because the risk of ischemic stroke is going to be higher in those patients. If the microbleed count is more than 10, then you have to exercise caution. So TIA is something we commonly see in our outpatient department, and I'm sure you're all familiar with the CHATS2-VAS score. And anyone who's got a score of 1 and who's female should be offered anticoagulation, or men with a score of 2 and above should be offered anticoagulation. And you can see if they have left ventricle reduced ejection fraction of 40 and below, presence of hypertension, age more than 75, you give 2 points. Prior stroke, give 2 points. Diabetes, you give a score of 1. And at the end, if they have a score of, say, for example, 4, the adjusted stroke rate per year is almost 4%. If they have a risk of score of 9, they are likely to have a stroke at the rate of 15% in the next year. So these patients with atrial fibrillation should be offered anticoagulation. In olden times, we used to use azithromycin, but nowadays we have moved on to dabigatran, rivaroxaban, and apixaban. So apart from hypertension, diabetes, atrial fibrillation, the other commonly overlooked risk factor is blood pressure variability. Having a persistently high blood pressure alone is not a major risk factor. If somebody has variable blood pressure, labile blood pressure, the risk of MI and strokes are much higher in this population. And if you do a 24-hour ambulatory blood pressure, those who have diabetes tend to have autonomic neuropathy, and also have renal and carotid stenosis, which increases the chance of BP variability. So you can classify your patients. Normally, when we go to sleep at night, your blood pressure dips, and there are patients who may have extreme dips in blood pressure, and there are some who may have reverse phenomena where they have a slightly elevated blood pressure. And most of us will have a morning surge in blood pressure. And quite often you would notice that when you're on call, you see quite a few admissions coming in the early mornings with MI, strokes, and even pulmonary edema. So in those patients, it's better to go back and check the ambulatory blood pressure and introduce antihypertensive at night time. So before you introduce that, just to make sure they are non-dippers or they are reverse dippers, and then introduce appropriate medications. So you all know type 2 diabetes is a progressive disease. As time goes on, from prevention, you move on to oral anti-diabetic drugs and then insulin. Macro and microvascular complications increase. So I just want to touch a little bit on the use of aspirin and statins in various patients with hypertension and other risk factors. So we tend to get asked this question quite frequently. Is there a role for aspirin in primary prevention? And a lot of studies have said giving aspirin without the presence of MI or stroke can increase GI bleed risk. And you can use this scale, ASCVD scale, which is there online, and choose your patients appropriately. And those who have higher LDL and a higher risk source should be offered high intensity statins, meaning atorvastatin 40 to 80 or rosuvastatin 20 to 40. So this is quite a daunting list. So I'm not a diabetologist, but we all get confused with the addition of newer agents. Almost every year or month we get to see newer agents, and quite a lot of drugs have come up. So you have DPP-4 inhibitors, GLP-1 agonist, and SGLT2 inhibitors. There are quite a few studies looking at the specific drugs against stroke reduction, and this is a systematic review and meta-analysis looking at quite a nice study looking at the instance of how do SGLT2 inhibitors or GLP-1 agonist and DPP-4 inhibitors compare in reducing mortality and cardiovascular events in patients with type 2 diabetes. So what it concluded was the use of SGLT2 or GLP-1 agonist was associated with a lower mortality than DPP-4, and use of DPP-4 inhibitors was not associated with lower mortality than placebo or no treatment. So it's a good information to know that those who have a higher or prior TIA stroke, the choice should be SGLT2 or GLP-1. So there are quite a few ways how these drugs give a positive effect. So I'll just skip. So in this meta-analysis looking at various GLP-1 agonists, they specifically looked at fatal and non-fatal stroke, and all of them favored the use of GLP-1 RA in those patients. So there is a new sort of algorithm that just come out in the March edition of Stroke, which suggests that if somebody has type 2 diabetes with a history of prior stroke or TIA, and if they are on DPP-4, the advice is to stop it and add GLP-1. And if they are on sulfonylurea, then you follow the pathway and update, review and check the HbA1c. And if the HbA1c is more than 8, there's no adjustment necessary. But if it's less than 8, you have to be worrying about risk of hypoglycemia in those patients. So GLP-1 RA is the drug of choice in patients with stroke or prior TIAs. Obviously, these are costlier drugs. We have to make sure they're able to afford it also. And maybe in future, the cost hopefully may come down. So there are some patients who we are quite pleased. They get a thrombolysis, they go home within the same week or month, same week or few days time. And some patients, despite having good recanalization, they end up with hemorrhagic transformation or malignant MCA infarction, getting hemicranectomy. And there are quite a lot of studies going into this sort of population to see why some patients do well and why others don't. And we have come up with a set of different brackets of patients where some patients are fast infarct progressors. And we recently have a patient who came in to the hospital within 2 hours of onset. She had her IV TPA within 2 hours. Then she went to the cath lab. We did a thrombectomy, and she had complete recanalization by 4.5 hours from the onset of a stroke. But despite that, next day she had a completed infarct, and we took her for hemicranectomy, and she's doing well, meaning she hasn't lost her life. She's still having dense hemiparesis. But normally we would see patients who have had a good treatment with IV recanalization to have a successful outcome. But there are some patients who have poor outcomes despite what we do. So that is mainly because of poor collateral flow. I mean, we all talk about brain and time, but there is a newer clock called collateral clock. If somebody has poor collateral, whatever you do, they may not do well. And there are some patients who have variations of circle of Willis. So the ICA may contribute to both the ACAs on one side. They may simply have both the PCAs arising from the ICA. The demand on the ICA is very high. And if somebody has a carotid T or carotid L occlusion, the ischemic cytokine release is very high. Presence of diabetes, presence of sepsis, and CKD increases risk of bleed and infarct progression. There is a small subgroup of patients who have hypo or afibrinogenemia, which we won't know at the time of hospitalization. These are the patients who tend to develop massive bleed after IV TPA. So this is a slide which shows on the top left, you have a patient with poor collaterals. On the right, you can see the MCA on the right side, but the MCA on the left is not visible, and they tend to have a very large infarct. And the row on the middle shows somebody with reasonable collaterals, and the infarct is mostly on the gyral area. It's got lamina necrosis. And the bottom slide shows somebody with a tight M1 stenosis on the right, but they have got very good collaterals. You can see a lot of vessels on the cortical surfaces, and the infarct is very tiny in the lentiform. So as soon as somebody comes in, when you try to do your scan, always get a CT angiogram at the same time. And the CT angiogram can give a lot of information about the collaterals. And if somebody has good collaterals, and even after IV thrombolysis, if they are not showing improvement, then they should be taken up for IV, endovascular therapy, intraarterial therapy. So the take-home message is stroke patients with dysglycemia need prompt CBG correction. So they have to monitor them closely for secondary complications like infarct or hematoma expansion. They are higher risk for infections. As I said, if one of your stroke patients had aspiration pneumonia during their stay in hospital, the risk of death is almost 90%. The high admission CBG is a surrogate marker of poor outcome, and be prompt in identifying targets for primary and secondary prevention. Peripheral vascular screening is a very good bedside tool to screen patients who may have carotid disease, and use of new agents obviously is going to be the new way forward. Thank you very much.
Thank you very much, sir, for the elaborate discussion on stroke and diabetes. Any questions from the audience? Sir has clearly highlighted the entire detailed session about stroke and diabetes. So what all things to be done, what to be not done. Any questions from the postgraduates? Busy. Sir, I have two questions, sir. One is the DPP4 inhibitors. Actually, the ADA recommendations for cardiorenal, they have suggested SGLT2. So far, the DPP4, one of the slides you told there is no harm.
No harm.
No, it doesn't give any extra benefit. But you said you should stop DPP4. So any particular reason it is doing harm or neutral?
In the meta-analysis, they found that the benefit was not even equal to the placebo. So there's obviously no harm, but it is not because of the cost, and the long-term benefit is not seen in those patients.
So it was not equal to placebo itself.
Yes.
It's below placebo.
Yes.
So how does it harm? We don't know whether there are receptors there where by blocking it worsens the.
So it's only a meta-analysis.
So still not recommendations. Because so far ADA has not. Another thing, the SGLT2 you are told is one of the trials which has proven, but
Yes.
still ADA has not endorsed. I think still it has not included SGLT2 in the side. That is one thing. Regarding the endovascular, sir, we know the TPA 4.5 years the time window. The thrombectomy till what time you can do?
So the current guidelines is anything up to 8 hours in the anterior circulation, but in the posterior circulation we can even go up beyond 12 hours. So we had a patient from Chengalpet who came to us during COVID time, and by the time she reached to us, she was almost 12 hours. And on the MRI, there was a top of the basilar occlusion, and she had a very small infarct in bilateral paramedian thalamus, and that's why she was drowsy. So everybody thought she's gone. We took her for thrombectomy, and she's survived the whole thing, and she's coming back to her OP. So, and there are patients who we have done thrombectomy even up to 18 hours, especially in the posterior circulation. In the anterior circulation, it is about 8 hours.
8 hours.
And again, it is the time window is going to be changed very soon. With multimodal imaging, we can pick up patients who may still have penumbra even at 24 hours. So there are patients who may have very good collaterals, and because of stunning in the neurons, they may not have a proper motor response when we examine them. But those patients, if they have penumbra, salvageable penumbra, even at 24 hours, we may still be able to get them back to life.
So you decide on the imaging and then decide.
Yes. So multimodal imaging, which involves perfusion scan, looking at cerebral blood flow, time to peak, and also the collateral information will guide us. So it's going to be quite exciting. Like what happened in coronary artery disease, we are going to see a lot of interventions done for cerebral vascular disease, and I'm sure in another 5 years, 10 years, it's going to be. I mean, there are a lot of trials happening nowadays comparing IV TPA versus direct thrombectomy, and trials are moving more towards direct thrombectomy, and even IV TPA may not be around in another 5 to 10 years time.
Thank you, sir. So, take on citicoline and paracetam, those things you use in your practice, sir? Or?
Yes, but unfortunately, they don't have very huge clinical trial evidence. But anecdotal evidence based on our own colleague experience shows that, especially paracetam, it increases the speech output. The risk of
So, when do you
dementia
start?
is reduced.
So, when do you start? Soon after this thing, or when they're during the come for recovery?
So yes, soon after the arrival and also in the long-term period. But the problem is these drugs are quite costly.
Yeah, that's what.
And we have to be careful. There are a lot of patients who may have had a posterior circulation stroke, and I'm sure they may not have much benefit in these
Benefit.
drugs. So if they have cognitive variability, if they have a speech output problem, then paracetam has some value, I think. So.
Citicoline, sir?
Yes, citicoline
Both.
and paracetam. Both.
Thank you, sir.
Thank you, sir.
I think we are only interacting. Any postgraduates would like to ask questions? Then we'll ask. Thank you, sir. Thanks for your.
What is the role of cerebrolysin in the ischemic strokes? Sir? Is it really beneficial or?
So yes, I have seen used it with mixed effects. We had a patient who had got a lot of edema, and after cerebrolysin, the edema came down quite nicely. But quite often, they tend to develop thrombophlebitis. So cerebrolysin has to be used in a dedicated IV line. So they're all derived from proteins. And if one of your stroke patients has developed a simple thrombophlebitis, it pushes their discharge date by almost 2 weeks. So that will make them drowsy. And I've seen quite a lot of anaphylactoid reactions if the nurses are not careful enough to keep the line dedicated for this particular drug. And if they infuse other medicines, antibiotics or other chemicals, it causes a lot of anaphylactic reactions. So yes, it has some role, but the information is they should not be used without proper care.
Thanks for your very clear lecture, sir. I would like to.
One question, sir. Sir, in hypertension with CVA, what is the level of BP we have to maintain?
So immediately after stroke, it is wiser not to lower blood pressure at all unless they have a bleed. If it is hemorrhagic stroke, the target is 140 over 90. In ischemic stroke, and if you are going to thrombolize them, then only we bring it to 185 over 100. If they are out of window and if you are not going to thrombolize, it is better not to treat the blood pressure at all. And quite often the blood pressure will come down by its own by day 2 or 3. And that's how the international guidelines are.
Thank you, sir.
Thanks.
And I like the way you said, sir, peripheral vascular disease. I always use this point to my PGs also. Palpate the carotids. If the carotids are not palpable, or if there is an AS murmur, stenotic murmur, I'll tell them this patient is more prone for a stroke and an MI. It's a surrogate marker. Okay. Beautifully said, sir. I have some more questions to ask if the administrator provides. Sir, you said that PFO stuff. How often you come across? Because we see a lot of cryptogenic strokes with PFOs, number one. Number two, once there is a hemorrhagic transformation, our PGs tend to stop the drugs. Either dual antiplatelets, any antiplatelet, they tend to stop. That one, number two. Number three, most of the diabetics are with the microvascular atherosclerosis. How do you intervene, sir?
Okay.
Very small vessel. What are the complications because you push the thrombi in and all that?
So thanks for 3 beautiful questions. The first question is about PFO. So the PFO is such a common occurrence. So nearly 20% of the world population noted to have PFOs. And if you look, everybody in this room, I'm sure there will be at least 10-15 of us with PFOs. And interesting point is people who have PFOs tend to have increased risk of migraine. So if you have migraine, think of PFO. And patients with PFOs, not all of them end up with strokes. But if somebody with stroke and if you have extensively investigated and if they have PFO, then it's a big dilemma whether to close it or not. But if somebody is young age and if they had a large stroke, the other interesting thing is PFO strokes tend to affect the insular cortex for some reason. And most of my PFO strokes they have been in the anterior frontal lobe by insular cortex. So if you have somebody with insular cortex stroke, think of PFO. So yes, if once you have PFO, the current studies initially showed equipoise. Now the our guideline is to try and close them, and after closure, they may have a period of short anticoagulation followed by antiplatelet use. And there are quite a good pair of hands in Chennai. A lot of cardiologists who do PFO's procedures. The next question was about.
The hemorrhagic transformation,
Yes,
what
yes,
to stop?
yes. So hemorrhagic transformation. So if you look at microscopic level after any stroke, there is going to be some amount of hemorrhagic transformation. So if you do MRI, you will see more SWA changes into the infarcts. So in those patients, I never tend to stop the anticoagulation. If it is PH1, PH2, yes, you have to at least make it simple as single antiplatelets for at least 2 weeks, and then we can escalate to dual antiplatelets. If somebody who's on 2 antiplatelets and they come in with a stroke, then it's a very tough situation. You are bound to have more sort of antiplatelet activity. So in those patients, the guidelines, the studies have not come up with anything new, but we tend to use aspirin followed by ticagrelor twice daily. And even in those patients, the risk of hemorrhagic, the presence of hemorrhagic transformation does not increase the risk of bleed further down, to be honest. So the actual hemorrhagic transformation happens at the time of reperfusion. So they don't have subsequent hemorrhagic
Any
expansion
choice for
unless they are going
anticoagulation?
to be an anticoagulation, or they are going to have higher dose aspirin or dual antiplatelets. So we can scale down for 2 weeks and then, but not to stop it completely. We
Any
can scale
choice
down and
for
then carry on.
Choice of antiplatelets, sir. Which one you prefer, and you screen for this clopidogrel insensitivity in your written practice?
So the current guideline is to use 300 mg aspirin for 2 weeks, followed by dual antiplatelets. Or if somebody had a small or moderate stroke, we can get them home on single agent like clopidogrel. So clopidogrel is much better in terms of antiplatelet activity than aspirin. So if somebody is on clopidogrel and if they come in with a stroke, obviously we may do analysis to see if they have aspirin resistance or clopidogrel resistance. In those patients, there are quite a few studies coming up with low-dose rivaroxaban plus a single antiplatelet agent. And in patients with microvascular arterial disease, so the current endovascular catheters, they can only reach up to carotids and the M1, M2 segments of middle cerebral artery. So if they are in the distal branches, we cannot do much. So we can only intervene if it is a large artery atheroma, a large artery thrombus.
Before putting clopidogrel, do you routinely screen for ADP activities?
Yes, so it's part of our routine workup. Yes.
I think your point is well taken, sir. Even post PTCA, they are moving away, cardiologists are moving away from aspirin. They are going no aspirin. Instead, they go for clopidogrel and other stuffs.
Yes.
Great point, sir. And last question. In PTCA, they have, before doing the PTCA, now they are doing an FFR to see the flow rate. Is there anything you are advancing towards that?
So, but unlike heart, brain is an unforgiving organ. So, if you do anything heroic, and if you have an infarct, it is not going to be beneficial for the patient. But in coronaries, often they tend to have a lot of subendocardial and extensive collaterals. And even if a particular myocardial tissue is damaged permanently, the rest of the muscle will help the person. But in brain is, so we haven't gone to that level with brain apart from thrombectomies.
If there are no further questions, we'll wind up the session. Thank you so much, sir, for your elaborate lecture. Thank you.
Thank you.
Right, Dr. M. Leonard Stanley Chauha sir and Dr. Ramakrishnan sir to felicitate the speaker, Dr. Sivaranjan sir. TKV Sharavanan sir to felicitate our moderators, Dr. Leonard Stanley sir and Dr. Ramakrishnan sir.